Before we start, I will take just few minutes to take a feedback and ask and tell some things. Just tell me one thing. Who among you reads Morgan? Please raise the hand, please. Will you be able to answer, any one of you? No? Okay. So there is a lot of debates going on in different WhatsApp group, and I received this feedback and comments that because Morgan is being is an American book and it's an excellent source, and people are all over the world are reading it. But my simple question is that, are you able to understand or grab or get the message from Morgan? If you are able to answer,
No.
No. So what is the problem you face? In the morning, I said the question about burn. Okay. So if any one of you have had a look on these questions, so just tell me, is it possible to prepare that topic of burn from Morgan? If anyone of you have read this topic from Morgan. So my plea, my request to all of you, that I don't have any conflict of interest with Morgan. Okay. It is just that I have suffered a lot when I used to study this book, and I don't used to understand anything. And I thought that I am a stupid person, that I'm not able to understand. All others are very special and they are able to understand. But later on, when I understand that all of them who used to say that we are reading Morgan and we are understanding everything, unfortunately, majority of them were lying. Okay. Because I can bet on it that Morgan is such a pathetic book that it is an insult of the word book for that source. Okay. You will not able to understand any concept. There is no symmetry. There is no pattern. There is no topic in that book is covered in a way that you can say, okay, I have read this topic from Morgan, and that's it. I don't need anything else or any other thing which may be asked in the exam. So I can bet on it that if any one of you challenge, it's an open challenge for all of you, that you name any topic which you read from that book and all the aspects are covered. So if a source is so terrible, my humble request to all of you, that why are you so obsessed to read still that terrible book? Okay, this is my humble plea to start with. Okay, so try to understand this theory. You should be knowing the topic. For example, if I ask you what is what is I ask any question like what is Lahore, or what is Karachi, or what is New Delhi, or what is Riyadh, you are able to explain that Riyadh is the capital of
Me?
Riyadh is the capital of Saudi Arabia, and it's a big city. There are multicultural societies, things like that. Okay. If you are not able to explain any topic from that book, my humble request and my question, why are you wasting your time in it? Okay. So this is somebody has commented, maybe Morgan can be used as a review book after textbook. This is, and again, in Wes, I would like you to speak out. Just tell me one thing. What is the concept of textbook in anesthesia? Is there any concept of textbook of anesthesia? Anesthesia is a hell of a subject. You should be knowing each and everything, and I can guarantee you that there is no book in the world which is for anesthesia to whom you can say that it's a textbook. No, not even a single book is a textbook for anesthesia. I can guarantee, because you start from physiology, you start from anatomy, you should be knowing about the pathology, you should be knowing about the medicine. You should be knowing about the treatment patient is taking. You should be knowing about the interpretation and involvement of the other specialties. You should be knowing about physics. You should be knowing about basic sciences. You should be knowing about monitoring. So yeah, just and there is no like nothing is except for I think dermatology. Dermatology may be the only specialty in which is not being asked in anesthesia, I think, or least involved with anesthesia. Otherwise, you should be knowing each and every medicine. You should be knowing all the core topics of any medical science. You are in obstetrics, gynae ops, you should be knowing what is placenta previa. You should be knowing how to monitor the fetal heart rate. If you are in neuroanesthesia, you should be knowing what is the neurophysiology, what they are doing, what is bar hole, what is VP shunt, what is how CSF is produced, how CSF is drained. You should be like if you are talking about and so on and so forth. You should be knowing all the physiology. Well, just tell me one thing: which physiology you should not know? Respiratory physiology, cardiovascular physiology, electrolytes, any investigation. Like tell me one thing that which thing in medical science you should not know. So my humble request is that try to come out of this myth of a textbook. Please try to understand this thing that you should be knowing about the topic from in the way that if you are being asked ever, you are able to answer the question. That's it actually. That's the point which I want to highlight before now. We a number of people have joined, so we will start. In the morning, actually, I wrote these questions about burn and sent to all of you who are in the WhatsApp group may have seen it. So I will just start with because whenever you are considering about this topic of burn, there are certain things you should be knowing. Just tell me one thing: if the burn has occurred in the chest or in the limb, will it make a difference? If all of you interact and answer some of the question, it will become more easy for me to explain. If the burn is in chest and burn in the limb, is it something different? If it is only first degree burn or third degree burn, is it different? If it is like 30% burn or if it is 60% burn, does it make difference? If it is occurring in an 80 years old man or in 1 year baby, is it a difference? Okay. If the burn has occurred 1 hour ago and the burn has occurred 1 year ago, does it make a difference? Okay. Similarly, if you are thinking about monitoring, okay, does any difference in monitoring? If you are thinking about IV line, now we will just try to find out answers for everything. Just have a brainstorming at the moment. Will any IV line or invasive line will have any problem? Okay, then airway. Will there be problem in this patient's airway and others? If the patient there is smoke or a closed cavity burn, patient was in closed cavity, does it make any difference? If burn is associated with trauma, will it make any difference? If burn is a part like similar trauma or blast injury, okay. And similarly, the burn, if it is created by fire or it is created by chemicals or it is created by electricity, okay, will it be different? Okay. And when you are resuscitating about the fluids, whether you are giving colloids versus crystalloid, will it make a difference? Then we are giving 4 liters or 1 liter, will it make a difference? you are using suxamethonium within 24 hours or 1 year after, will it make a difference? Okay. So like there are so many other things about it as well. Okay. And there is there any concept of a dedicated burn unit? Okay. What will be the complications in the early phase and what will be the complication in later phase? Okay. And if it is circumferential burn, so will it create any problem? Okay, like compartment syndromes. Okay, whether it is one thing I left actually, if the patient is asthmatic or COPD or any other medical disease, will it have a difference? Okay, so now just think about it and we will just start that how to assess the severity of burn, like assess the like you will be assessing the nature of the burn. Okay, you will assess the site of the burn, because if it is in the thoracic area or if it is in the head and neck, it will create more problems. Okay, if it is occurring in a closed cavity where there is smoke inhalation, so that will be creating a lot of problem related to carbon monoxide poisoning, number one. And there will be airway edema. Airway edema, even if, for example, not directly like airway involvement, even carbon monoxide create a lot of problem because it will shift the hemoglobin dissociation curve to the left, and there will be a patient will be in trouble because carbon monoxide is has strong affinity to the hemoglobin, and it will patient will not be able to have the oxygen delivery. So this is one thing. And airway edema, so there will be certain signs, symptoms like soot in the nasal cavity or smoke. So that will lead to airway edema. Or if so, even the patient's airway is patent at the moment, maybe if you don't anticipate and you don't secure the airway, maybe after 1 hour or maybe after 30 minutes, you are not able to handle the patient because there will be resulting edema and you will lose the patient. Okay. So I have just given you an overview and a just mind exercise that now if you are able to find the answer to these questions from your holy Morgan, you can find them. No, I have no doubt and I have no problem. If you are able to answer these questions from Morgan, but I can guarantee you that these questions you will not be able to answer in the real spirit from that book. This is the problem. Anyways, so how will you assess the extent? How will you assess the extent? There are certain formulas about 999, rule of 9. And if it is the babies, the rule of palm, number of palm. So this like in that way you can assess that if it is involving the front of the arm or lower limbs, you will be assessing it. It is, I can show you the this is what all of you knows. Okay, so this is a rule of 9. So 1% front and back is 18%. This is similarly limbs are 18% and upper limb are total 18%. So that's how you will be calculating it. And if it is a younger age group, you will have to assess with the, if I'm not wrong, maybe it is written here or other book you will find that there is a wave by the palm. Just a second, let me show you. Does anyone knows about it? Maybe I'm not able to explain in the exact word what is this hand. I remember it because there's a little bit difference in calculating in the pediatrics. Am I right? Anyone wants to speak out? Okay. Just a second. Actually, these days,
What you are asking?
I'm sorry. My question
What
is
are you
how
asking, sir? What is the question?
yes, my
What are you
question is
looking for?
that how will you assess the extent of burn in pediatric patient? Because I remember I can recall that there is a way with the palm size, like we are calculating
Yes,
according. Sorry.
1% of the surface area is the patient palm. We can use it.
Yes.
And
Yes.
another is lump and router chart. And for every age, it is different. For 1 year, 2 year, 3 year, it is different.
Yes. I actually I just wanted to recall it, and I just want to show you because we are primarily these days we are trying to cover the topics being discussed in this book. Just give me like in this few minutes I have just given you an overview. Now we will just try to have different like in between. If I'm just finding it, what will be the concerns related to succinylcholine? Can you use it immediately? You can use it, okay? But if you later on, what happens? Why you are not able to use succinylcholine?
Because of hyperkalemia
Why it
resulted of
happens?
this
Why it
because of the destruction of the tissues caused by burn.
No, yeah, yes, you are right, but there is one more, like exactly there will be extra the like appreciation of the appearance of the extra junctional acetylcholine receptors, okay, which will result in significant hyperkalemia. Similar sort of thing occurs in the denervation which occurs after spinal cord injury, okay. So similar sort of picture. So that is the reason you should not use succinylcholine later on. And like if we just like discuss the same thing, that what will be the challenges, as I told you, that if you have a patient with airway involvement in burn like smoke or closed cavity, and you are expecting that there may be airway edema, so you should be intubating the patient early, okay, and you should be taking care of it. You can have inhalational induction, because maybe if you give muscle relaxant, maybe you are not able to intubate the patient, sorry, ventilate the patient, and there may be collapse. This will be variable in different scenarios. You can have nebulization with racemic epinephrine before to just to reduce the edema, okay, and then you can intubate the patient. This is important thing. The other, if later on, if you have a similar patient later on, if it is involving any like there is any contractures in the neck, any contractures in the mouth or face, then it becomes a difficult intubation in the way that there may be problems related to the neck movement and the problems related to the mouth opening, okay. So in that case scenario, you will not be able to have in that scenario the answer will be awake fiber optic, because you may not be able to have a proper laryngoscopy, okay. So later on, if you think about it, so that will be the problem. I talked about breathing, that if it is involving a circumferential area, which may contract, and that may result in actually restriction in the breathing, and there may be restriction in the vital capacity, and patient may go in failure, okay. So like this is especially in case of burn in the thoracic cavity, because when it is like there is edema and there is creation of patient will not be able to have the proper breathing. Okay, so circulation. Now the most important topic which they ask is about how to calculate the fluid and how to give it. There are so many formulas which is being used. The most common formula is this Parkland formula, which is this one: 4 ml per kg per person total body surface area in 24 hours. First half in 8 hours, and then later on the next 16 hours. So for example, just to be simplify the thing, if you have like patient with 100 kg and you have 10% burn, so 100 multiplied by 10 multiplied by 4, so it will be around 4 liters. So 2 liters you will give in first 8 hours, and the rest of it you will give in the next 16 hours. This will be in addition to the maintenance. And another thing is that
question here.
I'm sorry.
Sir, I have one question over here. That's you said 10% if there's a burn in the patient. So is it necessary to replace the fluid if the patient is taking orally?
You know, that's what I was about to answer, that it will be depending on the scenario. And this calculation is a rough calculation, okay, and more of theoretical. Practically speaking, you will be looking at the overall condition of the patient. You will have urine output monitored, okay. In either patient is passing urine, either patient I request all of you to mute the mic. Whosoever wants to speak out, just raise the hand. I will give the chance. Okay, Aisha. So the thing will be that you will be replacing the fluid with what you use the terminology goal-directed fluid therapy. The concept will be the same. This will be just an idea that maybe you might need that much fluid. Okay, and the rest, that's what they have written here. That initial resuscitation, you are required to give even more fluid than this one. Even in some condition, maybe if the patient is in hypotension, patient is in shock, patient is in hemodynamic instability, okay, and the degree of burn is too much, that like patient evaporation, patient is losing a lot of fluid, okay, so maybe you need to give even more than that, okay. And in other patient, you started the resuscitation, you follow it with ABGs, you are following it with urine output, you are following with the dehydration status, and you may reduce. And for example, if that's what I told you, that of a patient with cardiac failure, for example, would you like to give that much fluid? No. Okay. You will have to manage accordingly. This is a rough idea. This is a rough, and especially if you are appearing in oral part, you should say that these are the formula. This is what they have written here. People will only look here and they will miss this thing. There are several formulas that can help guide fluid management. It is not like that if you calculate it and open like a box and put 4 liters inside the body. It's not like that. Okay. So similar, my next question is that whenever you are giving any fluid, you have certain things by which you can guide and you can monitor your fluid administration. So what will be those signs? Like clinical signs, symptoms. Similarly, what they have written here: heart rate, blood pressure, capillary refill, CVP, urine output, okay, and general mental status of the patient. And if, for example, if you have pulmonary artery catheter, it's not actually pulmonary artery catheter now is almost nobody is using it except for specialized cardiac center where they are in living in 80s, okay. So otherwise, there is no need for pulmonary artery catheter. You can have cardiac output monitoring. Okay. So you will be calculating. My question is that why not, and why yes, you want to give colloids early in the early resuscitation. Would you like to give colloids? If you don't want to give, why? Why you don't want to give colloids? You know, if you will speak out, believe me, I don't have anything to hit you people. Even if you answer wrong, I will not hit you. Yes, Aves.
Sir, in my opinion, colloid will be not the best.
You know, I'm sorry, Aves. Speak out loudly. We are not able to listen. If you are using mic, headphones, please remove it and speak directly. Your voice is coming very low.
Okay, sir. In my opinion, colloid is not the best fluid because it will not distribute intravascularly, extravascularly, intracellularly, and it will carry a risk of allergic reaction, and it can worsen the edema. So I would prefer crystalloid.
Okay, because actually the thing is that colloids are heavier molecules. Okay, initial phase of burn, there is a capillary leak. Okay, so if you are giving excess colloids, it will not help. Rather, it can create more problem because it will not stay in the vascular space and it will create more edema. Okay, but otherwise, you are talking about allergic reaction. Allergic reactions, yes. But if you have plasma proteins and you are using it just and as a help adjunct, there is no contraindication. Okay, like it is not like contraindicated to use colloid. Especially, I will label the patients who have limited cardiac reserve and you just momentarily support the hemodynamics. You can consider combination of colloids with crystalloids. Okay, that's the only point. There is no fixed rule. Remember one thing: there is no fixed, strict, hard and fast rule for fluid management. There are so many factors which will be affecting. You will be doing the serial ABGs. You will be following the flow volume status and replace it. But the use of colloids initially is because it will come out of the capillaries and there is no advantage. And so it is not risk versus benefit. There is not much advantage. This is one thing. Okay. So my other question was, what was it? Yes. Any question up till now? Just let me refocus because I forgot what I was saying. Yes, please. Yes. What about monitoring? Okay. I was about to discuss about monitoring. Now you have a patient burn. So how will you have the monitoring? Will it create a problem? How will you put ECG? How will you take blood pressure? How will you take pulse oximetry? Just imagine a patient of severe burn involving the upper limbs, involving the lower limbs. Is it a challenging thing? Yes, please. Yes, Avas.
Yes, sir. It is a challenging thing if your both of the limbs are burned. Then how are you going to use your non-invasive blood pressure monitoring? So I would suggest then, sir, I will go with invasive arterial line, and I can do that in
Yes,
one
patient might need
arterial.
invasive monitoring. Okay. And that will be because even you can take CVP and you can, because it will be a problem to take IV lines. Okay. So venipuncture is one of the option or no? Will it be possible to have a surgical venipuncture?
Yes, sir. We can have that.
Yes. Okay. So this will be one thing. Just think about it, and you will have a challenging situation. So you can use ultrasound if it is possible. The things which can help you will be like maybe ultrasound, use of ultrasound, and invasive line. Again, this is a question mark because there is no clear-cut answer, and it will be different in different people. It is not like every burn patient you are not able to take IV lines, but this should be in your mind, and the surgeon is telling you, and there is a call from emergency that we are bringing a patient with burn. So that thing should be in your mind that you might have. And what about ECG? I have never seen it, but it is said there are some needle electrodes, so which may be used in this scenario. Okay, there are some needle electrodes. I have never seen it. I have just read about it that there is some needle electrodes which may be need for ECG monitoring. Okay. And in that scenario, if pulse oximetry is not working, not properly, end-tidal CO2 will give you a lot of information, and you can repeat ABGs. Okay, because maybe you will not find any place to put the pulse oximeter. Okay, You can use the ear lobule, you can use any digit, but if you maybe you will have a scenario, a challenge where you will have nothing. Okay. So in ABGs, you will be, because in normal ABGs, you will not be able to, in some machines, they are giving you the carboxyhemoglobin level. Otherwise, you will need the hemoglobin electrophoresis, and you will consider management of carbon monoxide poisoning, like in the form of hyperbaric oxygen, or because there are different ways to treat. If you are giving oxygen, there will be a certain period of time in which you will get it treated. Let me show you. Actually, this is here. Okay, this is about carbon monoxide poisoning, that if you are using it air, it will take 4 to 5 hours. If you are giving it normal 100% oxygen, so if you are giving normal 100% oxygen, it will take 40 to 80 minutes. And if you are using hyperbaric oxygen, it will take 23 to 25 minutes. Okay, this is simple. This question may come, and actually it is coming in MCQs. Okay, so similarly, when you are thinking about hyperbaric oxygen, you should be knowing what is the working principle of hyperbaric oxygen, why you use it. Anyone, please? What is the working principle, how you use and why you use hyperbaric oxygen?
We displace.
I'm sorry, I just mute you. Please unmute again, Dr. Rahman.
Sir, we displace carbon monoxide by providing 100% and hyperbaric oxygen, because carbon dioxide has a high affinity and compared to oxygen. So we provide 100% with high pressure oxygen.
Is your answer accurate? Does anyone disagree to this answer? Dr. Dora, I would like to listen from you. Is Dr. Dora is here or no? Yes, please. Is it the answer? Anyone, please? Yes, Dr. Awais.
Sir, hyperbaric oxygen therapy is provided in a chamber in which the pressure is greater than atmospheric or sea level.
Awais, try to speak a little louder.
Sir, hyperbaric oxygen therapy is provided in a closed chamber in which the pressure is greater than atmospheric pressure or sea level.
Okay. So what happens? If you can recall the oxygen delivery, what are you doing it? Usually, oxygen is being delivered. Usually, oxygen is being delivered mainly by the hemoglobin. Okay. When there is carbon monoxide poisoning, the carbon monoxide is bound to the hemoglobin, and hemoglobin is not being utilized for the oxygen delivery. When you are giving hyperbaric oxygen, you are trying to increase the oxygen carried by in the dissolved form. Okay. So this is the mechanism that you are increasing the oxygen delivery. And carbon monoxide will be, when you are giving 100% oxygen, gradually carbon monoxide levels will start decreasing. Okay. So clear your concept. Hyperbaric oxygen is only increasing the oxygen delivery. Okay. So that is because the problem is that if you have a hemoglobin which is bound to carbon monoxide, and oxygen delivery is not occurring, so how patient will survive in that time? So you are increasing the oxygen content by giving hyperbaric oxygen. Okay. Are you clear now? That's what is written here. Okay. Just a second. There is a reduction in the availability of oxygen binding sites, and therefore reduction in oxygen carrying capacity. Okay. Carbon monoxide interacts with the remaining hemoglobin molecule to increase affinity for the oxygen it carries. This results in shift of left hemoglobin dissociation curve to the left. thus oxygen delivery is further reduced. So you are increasing the oxygen delivery by giving hyperbaric. Okay. So hyperbaric oxygen therapy can provide nearly all the body's oxygen need purely from the dissolved oxygen. Now you understand? That is the difference between getting a concept and reading only a book. So now if you are able to, yes, Aves, speak loud, okay?
No, sir, it's okay. I have got the concept.
Thank you
That's
very
the
much.
stage.
You know that's a barakah of the people around, that you clear your concepts. Okay, that's what you will never be able to get while you are reading alone, reading books, especially the book against which I am doing this all jihad. I will say it, I am doing, this is a fight between the concept of tunnel vision created by one book reading and the concept of topic oriented, task oriented, conceptual study. And I can guarantee you will never miss the MCQs. I can guarantee you this. I can challenge you that if you have got the concept, you will be able to answer the question. Do you see? Unfortunately, your concept was wrong. Okay. So I hope now your concept is clear. So few words that there are certain other conditions in which you are using hyperbaric oxygen therapy, the gas gangrene and like severe infections, things like that. So because carbon monoxide is not our primary topic of discussion. Okay. So up till now, we have discussed about some aspects about the concept, how to assess the severity, site, problems, contractures. Like if it is in the abdomen, it can create abdominal compartment syndrome. Okay. So abdominal compartment syndrome is not only the abdominal hypertension. It is not the increased abdominal pressure. It is increased abdominal pressure with resulting in newly developed organ dysfunction. Okay. Like patient did not have renal failure, but now after the burn, patient started having renal failure in not only because of the reduced blood supply, but also because of dehydration. So now you will label it as abdominal compartment syndrome. Or similarly, you started having gut gangrene because the blood supply is hampered or things like that. Okay. So it is increase intra-abdominal pressure with resulting newly developed organ dysfunction. Okay. So that is abdominal compartment syndrome. Similarly, you can have a problem, as I told you, that there may be problem in the ventilation because there contracture in the chest. Okay. So similarly, another problem will be that increased nutritional requirement, because there will be enhanced catabolism. Okay. So there will be, you should be taking care of the nutrition of the patient, because otherwise patient will go in negative nitrogen balance and it create a lot of problem. Then stress, there will be severe stress related hormones being secreted, and that is also creating more and more problems. Okay. So because now the skin is open, so skin is a protection against the infections. So now any bug which is coming will create infections. So the patient is at risk of going to sepsis. Patient can go, because this is also a thrombotic state. The patient may be dehydrated also. The patient may go into DIC. So if you just have a look here on the complication which can occur. So because it will be a very hypermetabolic state, so maybe there is resistance to like, for example, if you are using atracurium or cisatracurium, there will be resistant. There will be a lot of more requirement because this is a hypermetabolic state. So maybe you are requiring it more and more. Similarly, if there is as a part of polytrauma or any other problems, so there may be rhabdomyolysis, which is also a factor against the renal failure. Okay. So, I will stop here today, and we will cover the rest of the aspects of the burn tomorrow, inshallah. Okay. Probably slightly earlier time, around 9 p.m. Pakistan time. Okay. So I hope you understand. And any questions from our discussion at the moment? So I will suggest you to have a look on the link. Okay. This one, I will share it with the, when I will upload, You will find almost all the questions I shared in the this one WhatsApp before. I will share again, and just try to read about it, and we will try to cover the rest of the concept or rest of the aspects of burn. Okay. So thanks a lot, all of you. Yes, Dr. Lutfia.
Excuse me, sir, I have just one question regarding the colloid or crystalloid.
Okay.
Your idea, it was because there is an increase in the capillary permeability. So that's why we don't need to give, or it's not helpful to give a colloid.
Okay.
Because it has a large molecular weight.
Yes.
But if I think logically, if I think logically, I thought I give something with large molecular weight, it will stop the leaking.
Your concept may be correct, but practically it does not happen like that. Practically, if you are there is capillary leak, like there is destruction, so everything is coming out.
So it will happen with crystalloid as well.
But we are giving in high volume. Colloid volume is less. Your point is 100% valid. Okay, but that's what is written, and that's what we have to follow as. But practically, I told you, I would like to give colloids as well. Practically, things are a little different. Okay, I will think further, and I will try to answer your question in a better way tomorrow. Okay, but
thank you.
That's what I know. Okay, that's what I know, that it is recommended to avoid, or you can say that there is no advantage of giving colloids in the early phase, but it cannot block the bleed this leakage. Okay.
Okay, thank you so much. Thank you.